team here. We would like to welcome you.
Thank you.
Maybe
Let
we
me
will
stop
stay.
sharing so that the
No, that's okay. I
participants.
think
Yeah.
we can have your PPT. We'll just wait for a minute or so more, and then we'll
Okay.
start with your introduction, followed by your talk.
All right.
All right, so Professor Vidyasagar, your session is being recorded,
Okay.
and while you do not need any introduction, this is really our great pleasure to have you with us. But just for the participant benefit, I'll briefly read out your biography. So, good evening, everyone. We are very pleased to have the eminent speaker with us today, Dr. Vidyasagar, who is the SERB-National Chair at IIT Hyderabad. Uh, he received his BS, MS, and PhD degrees in electrical engineering from University of Wisconsin in Madison. Then he taught at various universities in US and Canada. He returned back to India as director of the Center for Artificial Intelligence and Robotics in Bangalore in 1989 and joined TCS as an executive vice president in 2000. He then moved on to Hyderabad and set up the Advanced Technology Center. After retirement from TCS in 2009, he joined Texas as chair in System Biology Science. And between 2015 and 2019, he managed his time from UT Dallas and IIT Hyderabad. And now, since that time, he is the SERB-National Science Chair at IIT Hyderabad since 2019. He, of course, has received the numerous recognition and awards, which many of the participants are aware here. He's also the Fellow of the Royal Society. He is a IEEE Control Systems awardee, Rufus Olindberger Medal of ASME, John B. Regensley Education Award from AACC, and several other accolades goes to his credit. So we are very pleased to have Dr. Vidyasagar with us today, and we are now open for his presentation and followed by discussion.
Okay. Thank you. So thank you very much. The topic I chose is just about the only overlap I have between digital health and my research, and that is the modeling of the progression of the coronavirus from the starting point approximately in February, March of 2020 till now, so approximately a 2-year period. And we have gone through various stages and we have learned some lessons, mostly about modeling, but a little bit about electronic health as well. So I'll share that with you. So here are the two collaborators in what I'm going to talk about. On the left is Professor Manindra Agarwal, who is at IIT Kanpur, and on the right is Lieutenant General Madhuri Kanitkar. Actually, the slide is out of date. On Republic Day, she was also conferred with the PVSM. I'm sorry, I didn't notice that. So she retired from the army on October 31st, and since then she has been the Vice Chancellor of Maharashtra University in Health Sciences in Nashik. So here's a quick outline of the talk. First, I'll talk about pandemic models, early models followed by our model, which we call Sutra, and then the actual projections we made, predictions and projections for the three waves, the first wave, Delta wave, and the Omicron wave. The first wave can probably be called the Wuhan wave because it was triggered by the original virus. And I have just a few slides, nothing very profound, on what it takes to go beyond modeling towards digital health, which is the name of your center. So, what were our challenges in modeling COVID-19? The pandemic is called COVID-19, and the virus is called SARS-CoV-2. So, the first wave, which may be called the Wuhan wave, started approximately in March 2020. It peaked in September 2020 and pretty much died out by December. And in January, it was kind of static. And then in February or March, we began to see an uptick. And in March, it just exploded. And that was the Delta wave. And that lasted probably till about August or so. After that, the wave itself was kind of over, but everybody was somewhat spooked about the possibility of a third wave. And sure enough, that third wave came in the form of the Omicron variant. And it hit India towards the end of December. And as per our forecast, we expect that it will end by February of this year. That is later this month. So you can see that each wave is getting shorter and shorter. And I'll explain why as we go. So I'm going to point out that the challenges and aims and objectives for making models and forecasting were different in each of the three phases, even though it's the same pandemic. And it is not only because of this variant, there were other issues as well, which I'll mention. So let's start with pandemic models. So the very first model for a pandemic is called the SIR model. It was proposed by two people, Kermack and McKendrick, in 1927, 95 years ago. And interestingly, what they were attempting to do was to model the spread of the plague in the city of Pune, again, not far from where you are. So in their model, the population was divided into three categories. The susceptible people denoted by S, the infected people denoted by I, and the removed people denoted by R. Now, in a lot of these papers, you find that R stands for recovered, but we prefer to call R as removed. So this includes both those who recover and those who die. But the point is that either way, they cannot be susceptible again. And all these numbers are shown as fractions of the population. So they lie between 0 and 1. So the premise of this SIR model, number one, is that the rate of spread is proportional to the number of contacts between the S and I group. So that means if somebody from the S group comes in contact with somebody from the I group, with a certain probability, which is usually denoted by the symbol beta, a fresh infection takes place and the person from S gets infected and moves to I. In the basic SIR model, the premise is that those who recover are not liable for reinfection. But if you want to capture a situation where over a period of time, those who recover actually lose their immunity and return to being susceptible, this is called the SIRS model. So if it is a pandemic, like say smallpox, for example, where if you get it once, you won't get it again, then you use the SIR model. And if the immunity fades over time, like flu immunity with or without vaccination lasts about 6 to 8 months only, then you use the so-called SIRS model. So here's a picture showing what happens with the SIR model. Okay. So what happens with the SIR model? Excuse me, just 1 minute. So what happens with the SIR model is that the rate of change of S is proportional to I times S. So this is what I mentioned earlier. When a person from I comes in contact with a person from the S group, with a certain probability beta, a fresh infection takes place. So when a fresh infection takes place, that infection is subtracted from S and added to I. And then from the infected group, at another rate gamma, the people recover. So that's it. And in the SIRS, there would be one more arrow from R back to S. So these are the key parameters of the SIR model, beta and gamma. And the ratio between beta and gamma is called R0, the basic reproduction ratio. So many people, especially in the mass media nowadays, keep talking about R0. And you can think about it as the average number of people that an infected person can infect before he himself recovers. Okay. Now, one point I should mention here with this diagram is fresh infections happen only when I meets S. So if one I person meets another I person, nothing happens. I meets R, nothing happens. R meets S, R meets I, nothing happens. R meets S, nothing happens. This is the only way in which fresh infections can take place. It's a simplistic model, but it's surprisingly effective. So if this basic reproduction ratio is less than 1, it means that an infected person does not infect more people before he himself recovers. On the other hand, if R0 is more than 1, initially the pandemic will take off, number of infected people will rise, and when the number of susceptible people equals this ratio 1 over R0, and because S plus I plus R has to equal 1, because remember they're fractions, I plus R has to equal 1 minus 1 over R0 or R0 minus 1 over R0. And this is denoted by the symbol H, and it is often called the herd immunity ratio. So it denotes the tipping point at which the number of new infections is at a maximum. So for example, if the basic reproduction ratio is 4, substitute 4 into that formula, you get 3 over 4. So when 75% of the people are either currently infected or were infected in the past, then the pandemic starts receding. Now, there's a big difference between, can you still hear me?
Yeah.
Yeah, very.
Okay.
Please continue.
Yeah, because
Yeah.
the electricity just went off, I wanted to make sure that I was on the internet connection that had the UPS. Okay, good. So as I was saying that until about the 1970s or so, nobody bothered about calibrating the model. That is, you can write down these equations, that's fine. But if you measure I and measure R, how many people are getting sick, how many people are recovering, how do you determine the parameters of the model? So this led to the notion of herd immunity. Now, interestingly, most people don't realize that the phrase herd immunity was introduced by the people who worked in vaccination in the year 1923. It was just a vague idea that, namely, if you pick people at random from the population to vaccinate, what fraction of the population do you need to vaccinate in order to prevent the disease from spreading? That was the definition that was used in 1923. Okay? But there was no formula. Then a person called Smith in 1970 was the first person to give this formula. And interestingly, when Smith introduced this formula, what he used it for was to wait until the pandemic completely peaked and use that to estimate H. So in other words, if I go back to this bullet, instead of calculating R0 and determining what H should be, what Smith did was he calculated what H was by observation, what is the time at which the pandemic started receding, and from that tried to identify R0. And there was a paper written in 1986 by a person called Robert Heathcote, one of the founders of mathematical epidemiology, you can say. So what he did was, he didn't wait for the pandemic to be over. He could observe that initially, just go back to these equations, initially if S is very close to 0, pardon me, if initially S is very close to 1, because when the pandemic starts, almost everybody is susceptible. A few people are infected to trigger the pandemic and nobody has recovered. So you can put S is equal to 1, and then if you put S is equal to 1 into this formula, you can see that I will explode like at an exponential rate of beta minus gamma. I hope you can see that. So if you know gamma, you can infer beta. But how do you infer gamma? Well, you just look at this number, you just calculate the rate at which infected people are recovering. So if people are getting admitted to hospital, you just calculate the average duration of stay. And if the average stay is 10 days, then gamma is 1 over 10. So that was Heathcote's idea. But the problem was, his approach relied on S of 0 is approximately 1. So you can only calibrate at the start of the pandemic. So if something happened, like the virus changed its characteristic, his method was not applicable any longer. Now, sometime the same person, Heathcote, that I mentioned, he introduced another model called the SEIR model. I didn't draw a picture because it's. I didn't think I did. Yeah, I didn't draw the picture. It's just that between S and I, you put one more state called E. And the idea here is that if an S person comes in contact with an I person, the infected person doesn't straight away enter I as in the SIR model. Instead, they go to this intermediate box called E, which stands for exposed. And then after a certain period of time, they move to the infected box and then eventually to the recovered box. Now, the key in this SEIR model is that if a person who is in the exposed state, sort of like being incubated, comes in contact with a susceptible person, it does not lead to a fresh infection. That was the basis of this model. Now, it turns out that, so what do you know? If you're an epidemiologist and you try to use the SEIR model, what can you actually measure? Well, you know how many people are getting sick, so you can measure I. You can measure how many people are getting released, so you can measure R. And because these are fractions, you take I plus R, subtract from 1, that gives you S plus E. But you don't necessarily have a way of disambiguating between S and E individually. However, because of this assumption that when S people and E people come into contact, nothing happens, it's okay to know only S plus E. Now, it turns out that this rate at which people move from E to I cannot be estimated using caseload data because you don't know how many people are in E. So what people who use this model did was they do some petri dish experiments or something, and they assign the models as opposed to inferring the models based on data. Now, this is a very interesting paper which doesn't get the attention it deserves by two people called Robinson and Stelianakis. They said that no, we don't want E, we want A. That is asymptomatic people. And whether S comes into contact with A or S comes into contact with I, a fresh infection results at possibly a different rate. So you can see this here. If A comes to A meets S, there is one rate. If I meets S, there is a different rate. So everybody who's infected moves into the A bucket. Okay. So let me show on the next stage is much easier. So here the susceptible box, A box, I box. When A meets S, there is an infection at a rate beta. When I meets S, there is also an infection at possibly a different beta. Now, some people who are asymptomatically infected directly recover, and some people move into the infected bucket. And people who are infected recover. This is the so-called SAIR model. Now, interestingly, please pay attention to this date, 2013. So in the year 2013, nobody had ever seen a disease like this. So this looked like just a mathematical model with no particular relevance to anything. In fact, some people even went to the extent of calling this a hypothetical disease. However, once the coronavirus started in 2019, we know perfectly well this is no longer a hypothetical disease. There are both asymptomatically infected and infected people. Either type of contact leads to fresh infections. And most important, asymptomatic people can spread the pandemic. And there have been very carefully controlled studies to show that asymptomatic people and symptomatic people don't spread the disease at noticeably different rate. I hope you understood that sentence. The rate at which asymptomatic people spread and the rate at which infected people spread is pretty much the same. So you can assume these two constants are one common constant, and these two constants are also equal to another constant. Now, the question is, how do you infer all these parameters from case load data? So we can show, I mean, this is not a talk on mathematics, but please take my word for it that you can very reliably estimate gamma. What is gamma? It's the recovery rate. You can also very reliably estimate beta, which is the common rate of infection. But how do you estimate delta? Well, it turns out you can't estimate delta. In fact, what you can estimate is only beta plus delta. Now you may say, well, I know beta plus delta, therefore I just subtract the two and I get delta. However, there is a problem with that. The problem is delta, which is the rate at which asymptomatic people become infected. That means asymptomatic people develop visible symptoms. That's the rate delta. That is much smaller than the infection rate. So if you want to subtract beta from beta plus delta, what you're doing is subtracting two large numbers to get an estimate for a small number. Anybody who's ever done any statistics knows that this is really a bad idea. Okay. So, okay, does it really matter if you have a bad estimate of delta? Yes, it does, because you want to predict the peak of the pandemic, and unfortunately, the peak of the pandemic is proportional to 1 over delta. So bad estimates for delta lead to bad estimates for the peak level of infection. So if you're a modeler and trying to predict when the pandemic is going to peak, this particular approach is not useful. So this model is very difficult to calibrate. So now let me go to the Sutra model. Sutra stands for susceptible, undetected, tested positive, removed analysis. So here are the basic assumptions. Anybody who tests positive, almost all of them, are isolated and therefore they do not infect other people. Now, in the SAIR model, the premise was that if you're asymptomatic, you will not be detected, you escape detection. Unfortunately, that assumption is not true in reality because many countries, including India, adopted contact tracing. So if somebody tests positive, you test the family members, you test the neighbors, you test the vegetable vendors, servants, drivers, the whole bit. And you identify a whole lot of people who are infected. And what is interesting is most of the people who are identified as positive in this manner turn out to be asymptomatic. So if you're waiting for people with symptoms, you would never find them. So we made the observation that we should not distinguish between A and I, that asymptomatic and infected. The correct division is those between those who test positive. Because of this bullet, most of those who actually test positive are also asymptomatic. If you didn't understand that point, let me repeat. One person tests positive. So you test all the people around him. You may find that there are 20 others who are also testing positive. But the original person who showed symptoms is the only guy who is actually symptomatic. The remaining 20 are asymptomatic. This is very, very typical. in India. And then there's a whole mass of people who are undetected because they have never come into the radar of the healthcare system. So within T, most are asymptomatic. I've said this a couple of times already, and therefore there is no danger and they recover. And in U, either they have very mild symptoms or they are completely asymptomatic, so they also recover. So this is the key assumption of the Sutra model. That's why I have highlighted it. When an initial infection takes place, they all move to U, and the most recent entrants, some fraction of them move to T. So here is a picture. When an undetected person meets a susceptible person, there is a fresh infection. In our model, there is no arrow here. Why is there no arrow here? Either because these people are isolated and therefore have no opportunity to join S, or because the number of people in T is so small compared to the number of people in U that most of the infections are due to S and U contacts and not S and T contacts. So that actually seems to be valid. Now, once people enter U, the most recent entrants at some rate move into T. So what are the most recent entrants? They're entering, these people S are entering U at the rate beta SU. So you multiply by some constant epsilon, which we call the undetection rate, and they move into T, and then they recover or get removed. Now you notice I have not put two different constants, gamma T and gamma U, because the assumption is that there's very little difference between the two rates, and that actually is true in practice. Most people here are asymptomatic, so they recover at a certain rate. Most people here are also asymptomatic, so they recover at the same rate as these people. A somewhat smaller fraction may pass away, but then the period over which they pass away, that means get removed, is pretty much the same as the rate at which the asymptomatic people recover. So that's why we are justified in using the same constants in both places. So if you are interested, here are the equations. I'm not going to dwell on them much. Beta is the same as before. It's the contact rate, the rate at which contact leads to fresh infection. Gamma, as you can see here, is the recovery rate. Epsilon is this transfer rate from undetected to detected. Now the fourth parameter called reach, which is implicit, and I'll tell you where it comes later. So these are the four parameters: beta contact rate, gamma removal or recovery rate, undetection rate epsilon, and rho reach. Two of them are unique. What I mean by that is we are the first ones to introduce these two concepts. So this epsilon is an undetection ratio. What it tells you is how many people are you missing. And epsilon need not be a constant, but it is usually a constant provided the testing protocols do not change. The reason for this is that if more people get infected, they also come into the detection mechanism, so the fraction of people you are missing doesn't change. Now, one of the keys to the Sutra model is this mathematical observation that the ratio between the total number of cases, which is U plus T, to the cases that are tested positive is 1 over epsilon. Or you can say U divided by T is 1 over epsilon minus. So for example, if 1 over epsilon is 33, then for every person who tests positive, there are 32 other undetected cases. And I chose this number 33 because this is the value for India, but for various states, it can change. So for example, a state like Kerala has about 5.5 to 6, and a case like UP, a state like UP has over 100. So you have to apply this mental correction to find out the severity of the disease in various places. Now, what about this other symbol, rho? So rho is a very funny thing because you look at these equations, whether you understand the equations or not, one thing you can see very clearly is the symbol rho doesn't appear anywhere. Okay. So what's the point of rho? So rho is called the reach. What fraction of society is exposed to the pandemic? Initially, it starts at 0, and then as the pandemic spreads, it goes towards a 1. And this can be due to global factors, like, for example, pandemic may start in one part of the country and spread. But interestingly, we have found that when you do modeling for a state or even for a large city like Mumbai and Pune, there are variations in the reach. How do you explain this? Well, this is because even within cities, there are protected bubbles like gated communities, which are initially immune to the virus, and then they get penetrated by the virus and then causes an increase in rho. So if rho is a fraction of people who are exposed to the virus, it starts at 0 and increases towards 1. However, like what we have now in the Omicron wave, people who are vaccinated or people who have been exposed to the virus earlier and develop some immunity, they lose it. In which case, rho can increase beyond 1. And that increase tells you the loss of immunity. So how do you calibrate the beta model? Remember, I'm going on mentioning calibrating because the only thing you can really measure how many people are getting hospitalized, how many people are being discharged. That's all you have. Now, based on that, you have to make reliable estimates of all these 4 parameters. Now, gamma is very easy because let's go to this equation. You know how many people are testing positive, you know how many people are getting released. So based on that, you divide the two rates, that gives you gamma. So gamma is the easiest one to estimate. And in fact, in India, it has remained very constant at about 0.1, which means the average patient spends about 10 days in the hospital. Now with Omicron, this has gone to 0.2 because people are spending only 5 days in the hospital. But I'm just indicating that you can either estimate it or just fix it. It doesn't really matter. Epsilon, which is the undetection ratio, there is no way to estimate it directly. So what we do is we need one sero survey. For example, we have had about 3 different sero surveys in India. One in May of 20, one in August of 20, and one in I think there was one in January as well. So 4, and one in August of 21. So what we do is we try various values of epsilon and see which one fits the observations best. And epsilon seems to remain pretty constant. So for example, when there are multiple calibrations, as we have had in India, all calibrations, irrespective of which one you use, seem to lead to the same estimate for epsilon. Okay, so there are 2 of the 4, gamma and epsilon. How about the other 2? Beta, which is the contact rate, and rho, which is the reach. So you have to estimate the 2 of them together. And it can be established mathematically that there is a linear relationship between 2 different quantities. I won't tell you what they are because I presume this is a very general audience. But the key point is what I mentioned here. Both these 2 quantities can be computed from the caseload data, hospital admissions and discharges. One quantity is linear in the data and the other is a nonlinear function. So this linear relationship between these 2 quantities lies at the heart of the Sutra model. And this linear relationship holds after an initial mismatch period called a drift period. This can last anywhere between 10 to 14 days. So here's the picture. This is for Italy. And these are the various points. So if you are interested, this is one quantity which is a linear transformation of the data. This is another quantity which is a nonlinear transformation because of this product here. Anyway, you can see very nicely they are following in a straight line. And this R squared quantity, which is a measure of goodness of fit, is very, very close to 1. So what do we make of this? And what do we mean by phase? So the one thing that distinguishes Sutra from other approaches is we do not assume that the parameters of the model remain constant. Or to put it another way, we do not assume that the properties of the pandemic remain constant. So you go on plotting and plotting, and when it doesn't fall on a straight line anymore, then you know that you have to recalibrate. Something has changed. Either beta has changed or rho has changed or whatever. And when you try to fit the linear relationship again, just as you have at the beginning of the pandemic, there will be an initial very brief drift period. So the key point in our approach is, number one, you can detect when the parameters of the pandemic have changed. Nobody has to tell you. And number two, when the pandemic has changed, you are able to recalibrate the model on the fly, even in the midst of the pandemic. This is just about the only model I know that can be recalibrated in the middle of the pandemic. Previous calibration methods assumed S was approximately 1, which is only true at the start of the pandemic. So what the phase change? Well, you see the parameters of the pandemic do change, as I mentioned. So, for example, when people start disregarding COVID protocols, beta will increase slowly, it will drift upwards. Or if there's a new mutant, slowly the new mutant displaces the old mutant. But if there is something like a non-pharmaceutical intervention, like a lockdown, then beta will drop very sharply. And as I mentioned, I don't want to go through this again. This is the same bullet you've seen earlier. Rho starts at 0 and increases towards 1. So that's the Sutra methodology in a nutshell. So now let me talk about predictions, probably the part that everyone is waiting for. So in the first wave, there was this committee set up by the Department of Science and Technology. It was called the COVID-19 National Super Model Committee. I can assure you that I did not choose this title. I wouldn't have chosen such a pompous title. The title was chosen by DST. And there were a committee of 10 people. And we were asked to deliver 4 things. Model the spatio-temporal progression. That means with time and also across the geographies of India. Quantify the effect of non-pharmaceutical interventions like lockdowns. Make predictions for economic inventory like PPE, ventilators, stuff like that. And the fourth one was, how do you restore activity once the pandemic is over? So we delivered the first 3, but not the fourth, because in some sense, the pandemic never really went away. So what did we do? We predicted the course of the first wave pretty accurately till December 2020. We quantified the lives saved by the lockdown in March 2020, and we predicted medical inventory. This was done by a model called SAIR2 because it built upon this earlier model I showed you by Robinson and Stelianakis. Now, this SAIR2 model had the same shortcoming as all the other models. It could only be calibrated at the beginning. So, realizing this shortcoming, 3 of the people from the committee, whom I showed you at the beginning, Professor Agrawal, General Kanitkar, and I, started working further, and we developed this Sutra model. So let me show you some figures. So here, this gold-colored curve is what we actually predicted, and this blue-colored curve is what actually happened. Neither the blue nor the gold is very smooth because our data collection during the first wave was not that great. So now you can see that, the peak was 97,000. Okay. No, this is I beg your pardon. This is the active infections, not the daily infection. So active infections are approximately 10 times the daily infections because, as I told you already, gamma is 0.1. So this corresponds to 10 lakhs active infections or 1 lakh maximum daily cases. In reality, the peak was 97,000. And it didn't do a bad job. But here's the more interesting one. We were also asked to predict a kind of a counterfactual scenario. What would have happened if the lockdown had not been imposed? So we ran our model and we felt that the active infections would have peaked at about 17 lakhs, which means daily infections of 1.7 lakhs. That, as it turned out, was an overestimate. In reality, the active infections peaked later than we thought it would, and also at a lower level. But that's not the interesting point. The interesting point is this red curve here. What would have happened with no lockdown? With no lockdown, we predict that the peak would have come somewhere in May, middle or end of May, and it would have been around 48 lakhs active infections versus 10 lakhs. Okay. So what the lockdown did was brought down the peak demand on the healthcare system by a factor of nearly 5, and equally important, it pushed the peak out from the middle of May to the middle of September. It gave us 4 weeks to cope with the pandemic. Now remember, in March 2020, we had really nothing. We had no masks, we had no test kits, no ventilators, no PPE, nothing. So we had no Indian data also. So we had to make estimates for various things, especially for our estimate for ventilator was way too high. And why was it too high? Because we had no Indian data. We looked at the case numbers from Italy and Spain. And if you go back to that time period, people were really dying at shockingly high rates in these countries. So based on our estimates, a lot of ventilators were produced, and similarly, we overcame the shortage of masks, test kits, PPE, and so on. None of these is a big problem because they're all consumable items. So if you built up a big inventory, you can work through the inventory. Right now in India, we have far too many ventilators than we need. Well, okay, that cannot be helped. And we should also appreciate the giant strides made by India in all these things. Diagnostic kits. You would have seen in the newspaper that people in the United States are waiting several days to get a COVID test done, and they're also standing outside the so-called mobile vans where they do the swabbing. Here in India, people come home and you get the results in a day, basically. Okay, and similarly, the joint venture of Bharat Biotech and NCMR to develop the Covaxin vaccine. So I'll just put that out there. So let's come to the Delta wave. So by January 2021, we pretty much realized that the pandemic was not receding as we had predicted. By February 2021, we could see just a faint turn uptick of the pandemic. So we knew something was happening, but we didn't know what. Post facto, we knew what the problems were. First thing is that the coronavirus mutated into what later on came to be known as Delta. And in India, we had no genome sequencing capacity. I should say very, very little genome sequencing capacity. I should say certainly that everybody was complacent, not just the people, but even the Prime Minister. Here I have taken a quotation from his speech to Davos World Economic Forum in January 2021. In a country which is home to 18% of the world population, that country has saved humanity from a big disaster by containing corona effectively. We had spoken way too soon. And here is the link for that speech. And I think the general public also became very complacent. Okay, so what did we do? We were trying to calibrate the Sutra model. And what was clear was that the parameters were drifting very badly. So this is the part I was mentioning earlier. See, by 1st of February, it was not going down anymore. And by the end of February, it was beginning to go up actually. So we knew something was happening. So anyway, finally on April 29th, Professor Agrawal put out a tweet saying this is where we are, about 320,000, 330,000 new infections daily, 7-day average. And we predict that the peak will come. I'll go to the next slide. But what I want you to notice in this slide is we made the prediction here before the peak. Okay. So what we said was on April 29th, we said between May 5th and May 8th, the peak will be 3.8 lakhs. And we were off by 2 days. It happened on May 10th. And the peak was 3.9 lakhs, not 3.8, close enough. So this was an interesting study in psychology. The question is, why did anybody believe us? I don't think most people believed us because they thought we were great scientists. Frankly speaking, I think most people believed us because here the world looked like it was collapsing. Everything looked very grim. So when we came and said, don't worry, the end is very, very close. There's a light at the end of the tunnel. I think a lot of people believed us for only that reason. But once our predictions were borne out, I think our credibility went up. Many other modelers could not call this peak. People were making all kinds of numbers. But we were the only ones who predicted this thing. Now, I want to make one small point. If you want to model, you have to make verifiable predictions. There's no point saying that, yeah, I predicted 8 lakhs daily new cases, the rest are all undetected. Well, that doesn't mean anything. And I'm sorry, I don't get impressed by that. We make verifiable predictions. So by August, the Delta wave was clearly waning. So we were asked, what about the third wave? So we took a bunch of hypothetical scenarios. I won't go through the slide because I'm running out of time. Our conclusion was that India could cope with a variant that was 50% more infectious than Delta with the available hospital capacity that had been built up during the Delta wave. So now let's come to the Omicron wave. This is where we are now. So on the 26th of November, Dr. Anjali Coetzee, I hope I'm saying that name correctly, she announced to the world that there is a new variant has been isolated. And a lot of irresponsible statements by media and so-called scientists about how much more infectious it was. Whereas if you actually paid attention to Dr. Coetzee, she said that it spreads faster than Delta, but it caused shorter hospital stays and fewer deaths. Of course, nobody listened to her. But we did. We used South African data to run the Sutra model, figured out what the parameters were, and make some preliminary projections for India. So here's the South African data. So we ran a Sutra model. You can see a whole bunch of phase changes. That's not important. The key point is right there. You look at the first two waves of South Africa. They're what I'll call unimodal, right? Goes up, comes down. Goes up, comes down. What about the third wave? Goes up, comes down, and then takes another U-turn. What was the reason for that? So when we ran the Sutra model, we figured out that the contact rate, which was the beta, was 0.5 on 26th of July and 1.01 on 22nd August, more than double. So what was the reason for this? We don't know. We really don't know because the Omicron virus variant was isolated only in November. So we just decided to say an unusual increase in beta was observed in August 2021. We are not virologists, so we don't want to make more of a commitment on that, but there is this curious event which is still awaiting an explanation. So when it came to India, we had to address these kinds of questions. I mean, we knew surely that sooner or later it will come to India. It's not going to spare us. So to what extent does Omicron bypass vaccine-induced immunity? To what extent does Omicron bypass natural immunity? And people did some petri dish experiments to figure out how things get bypassed. But see, they don't accurately capture the behavior of the virus at the population level. And then South Africa suggested don't test asymptomatic contacts of symptomatic patients. Then UK adopted it, and then ICMR also adopted it. We thought it might reduce the number of reported cases, and one way of testing that was to look at the test positivity rate, whether it was increasing. So initially we started making some projections, not predictions, because we didn't have any Indian numbers. We just took South African data, extrapolated to the Indian context and ran simulation. So this is what we thought. There are three scenarios, sort of optimistic, in between, and pessimistic. And we felt that, as you can see, the daily new infections would be around 1.5 lakhs per day. So that's the red curve. Compared with 3.9 lakhs for the Delta wave. We made this prediction on 21st of December. Okay? And we presented it to various people. Now, what happened when Omicron actually showed up? Well, once it arrived in India, our estimates were revised sharply upwards because the increase in data in beta, the contact rate, was much higher than we anticipated. But rather surprisingly, this new testing protocol, which says don't test asymptomatic contacts of symptomatic patients, it only seemed to cause the undetection ratio to go by about 10%. And we could estimate that about 30% of the people have lost immunity. That you can show mathematically. That is from the parameter estimation. Ideally, we'd like to disambiguate between the loss of immunity of vaccinated people and the unvaccinated. Unfortunately, our model doesn't give a way of doing that. Hospitalization ratio is much lower than with Delta, as Dr. Coetzee told us. In major cities like Mumbai, Delhi, and so on, the hospital bed occupancy was only 25 to 30% of capacity. And also, the requirements for oxygen and ICU are also much lower than with Delta. So we are getting through this very comfortably. And as time went on, there were phase changes all over India. So I'm going to show you a few curves. Here is India, predictions made on 19th January. Okay. So, all right. I mean, till about the 10th of January, it was kind of following our prediction. Then suddenly it started deviating. We don't have an explanation for this. Is it possible that in everywhere coexisting are two groups of people? Some are very vulnerable to Omicron and some are not. So the variant burned through the first group and slowed down when it hit the second group. Unless you do very detailed studies, you cannot explain this. Okay, and I'm not going to waste your time by showing these graphs, but everywhere in India you could see the sudden departure from the predicted curve. So we had to recalibrate, and we did. We recalibrated on 31st of January, 2 days ago. Um, and so now you see it's matching a whole lot better, but with a phase change there. There's a phase change there. We had to recalibrate. And now you can see the peak has been reached. Now I wanted to put this thing here. When we made our predictions and we said that daily peak is going to be 7 to 8 lakhs, of course, everybody got spooked. But fortunately, it's not going to be anything like that. It's only going to be around 3 lakh. In fact, today's daily rate was about 1.6 lakh. Moving average is still about 2 lakhs. And coupled with the low hospitalization and the low oxygen and ICU requirement, we're going to get through quite fine. So it is, now remember, India is a composite of many, many different regions. So when you go to individual regions, you see quite interesting differences. Mumbai was the first city to peak, already peaked there and came way down. So now they're completely through almost. Bengaluru is, you can't really say it has peaked because it's still showing these wiggles and the parameters are still drifting. So this, you can see the phase change that started there, and we have not tried to adjust this gold curve for the new set of prediction because the parameters are still drifting. But for Karnataka as a whole, which of course includes Bengaluru, we could actually capture the new set of parameters, and we are predicting, you can see very faintly, peak occurred about 28, 29th, and it is now beginning to decrease. So the peak is just about now. I'll show you Bihar, because Bihar is an interesting case. The peak, so first of all, you see the famous phase change, started deviating from the predicted curve. Then it's slowing down. The recovery is much slower than before. See, most times the ascent slope and the descent slope are the same. In Bihar and even in Delhi, this is not the case. Ascent is faster than the descent. So much so that the blue curve, the actual cases have now climbed over the predicted curve, which was based on data until then. Okay. So we are waiting for the parameters to stabilize again, and we'll come out with a fresh set of prediction, especially when it is going to die down. That's about all I have for predictions, because I mean I can show you any number of graphs. I just wanted to pick 3 or 4 different typical cases. So I just have a few slides beyond modeling towards digital health. So first of all, our model is a versatile model that can be calibrated using only case load data. This we believe is our virtue. Not only can we make prognostications about what the load and health inventory is going to be going forward, but we can also quantify the impact of past policy decisions. That is, we can say, what if we hadn't done this? What would have happened? And what was the benefit of doing this like that? And the prediction of the peak of the Delta wave was, I think, a success story for us. We did that about 10 days beforehand, which is not a small lead time. So what are the lessons of the Omicron wave? Well, so we went through a series of steps. If you see, first we analyzed South Africa by itself. Then we just simply ported the South African changes into India to make our projections. Then once Omicron arrived, we didn't have to assume South African data. We had Indian data, so we call them predictions, not projections, but now they're predictions. But then because the parameters are beginning to drift, we have to continuously refine our predictions. Omicron clearly bypasses both natural and immunity and vaccination-induced immunity. In our model, we can calculate what is the total loss, but unfortunately, we cannot disambiguate between the two. So, this is really my last slide. In terms of digital health, above and beyond the model, you can think about two things. First is the importance of timely, accurate, and comprehensive data. See, Indian data portals aren't very good. I mean, we have to be honest and admit it. They're neither transparent, meaning getting data is not easy, nor are they timely, meaning they're not up to date. In contrast, we found South Africa's data to be really excellent. Now, if you want to use not dynamic, see, ours is a differential equations model. But suppose you want to use other methods like machine learning, you can do that when you have very accurate, timely data. And in terms of electronic medical record, if you want to talk about anytime, anywhere access to data, that's the only way in which it is going to happen. We have this portal called COVID-19tracker.in, which took over from where COVID-19india.org was earlier. And we discovered really just how digitally unfriendly official Indian data is. A lot of data has to be entered by hand, and that is definitely not the way to go. So that's all I have to say. And if people have any questions, I'll be very happy to answer them.
Thank you very much, Professor Vidyasagar, for a very interesting, engaging presentation. Very relevant to the Koita Center for Digital Health, especially the last note that you have left for us. I'd like to open the floor now for questions for Professor Vidyasagar. You could probably raise your hands or post your question on the chat.
Yeah, I'll not stop sharing in case somebody has a question about the slide. Then I can just go right back to that.
Sure, sure.
Can I ask?
Yes, please.
Yes, Dr. Bhandari, please go ahead.
Yes. As you mentioned, that Sutra model can recalibrate during, in the midst of pandemic, like when you saw new mutant strains like Omicron replacing the Delta. So my question is, to recalibrate, do you need any kind of maybe South African data helping you, or some data the particular sample size for clinically validate that?
No, that is actually used more by the INSACOG people, because what they were doing is to the data for October was 100% Delta, and data for November was about 75% Omicron and 25% Delta, and December it was 100% Omicron. So that tells you the speed at which it is displacing. In India, I think that the INSACOG people are doing similar surveys, but I'm not aware of what conclusions they have drawn. Now, as far as Sutra itself is concerned, we are not that much bothered about the mix of the variants because that can be captured as a drift of the beta parameter. So if initially you have a less infectious strain and it is getting replaced by a more infectious strain, then beta will begin to change. So that is what we try to capture using the Sutra model. So we don't use sequence information directly.
Thank you.
Thank you. There's a question from Aniruddha Sinha. Unless Aniruddha wants to speak, I'll read out the question. I didn't understand the concept about a linear and a non-linear function having a linear relationship between them. Could you explain, please?
No, the only way is to please read the paper. I mean, so what we really want to show is that the original equations are nonlinear. Okay. If you look at any equation, even the SIR model of Kermack and McKendrick, they're all nonlinear differential equations. And Sutra is also a nonlinear set of nonlinear differential equations. So we were able to show that there is a relationship between two quantities, which is linear, even though the underlying equations are nonlinear. Really, other than reading the paper, I don't think the simple explanation is possible. I'm sorry.
Thank you.
Is there anyone else? Yeah. Please go ahead, Daidi.
Hi, yeah, Professor Vidyasagar. It was a lovely talk, and the data and the modeling on Omicron is obviously fascinating, and what you called a phase change. So could that just be a dramatic change in the what you call the undetection rate? I think.
No, it was not. That the undetection rate only changed by about 10%. So we thought that once people stopped testing asymptomatic contacts of symptomatic people, the undetection ratio would go way up because there are all these people lurking around who should be tested, but they're not being tested. It doesn't seem to be, and we sort of figured out why, which is that many states were just simply ignoring the ICMR guidelines. Because, I mean, maybe they were not doing contact tracing even earlier. So, but whatever it is, the undetection ratio didn't go up much. But I think much more striking to me is all this within the country. Once Omicron arrived, why is it that everywhere there is a phase change? Sorry, electricity has finally come back. Why is it that everywhere there is a phase change after about 5-10 days? Now, one plausible explanation is that every particle group, that is not the whole country, not the whole state, not even the whole city, it's a mixture of people with various levels of vulnerability to the Omicron. And the Omicron sort of burns through the first group fast. And then when it hits the second group, it kind of slows down. But the only way to validate that is to do very detailed population level sampling. So all we can do is just throw up an idea and let others run with it, basically. But the phenomenon is very unmistakable. It's observed in every single state.
Right. So, but from what I understood, your model is updating these parameters on the fly.
Well, yes and no, in the sense that, first of all, when that linear relationship breaks down, you decide that there is a need to update.
Okay.
So you calculate those points daily. We calculate the points daily. But there's no guarantee that the resulting curve is still going to be on a straight line. So they'll be wandering all over the place. That's what we call the parameters drifting. And only when the daily updated calculations lie on a straight line for about 6 or 7 days, then we say, okay, now the parameters are no longer drifting. Now we can use these values to predict the caseload going forward. But depending on the time and place, the drift period can be fairly large. It can be 2 weeks, 3 weeks sometimes. It hasn't happened thus far. It happened more in the Delta wave. But so in other words, there's a distinction between knowing that you need to recalibrate because the old parameters don't apply anymore, and then figuring out what the new set of parameters is. That happens only when you get that straight line relationship, which takes some time. So is that clear?
Right. So, I mean, to me, what I got was that there's a protocol to saying that, okay, my parameters have changed and these are the new parameters that I would like to use.
Yeah, absolutely. That's a good way of putting it. We have a protocol for identifying the need to recalibrate and the procedure for recalibration, which kicks in when the linear relationship holds. So we're still trying to automate this to the extent possible. That's the only piece that requires a little bit of human intervention.
Right.
I mean, our dream is that you put in a time series of case data and out comes the model, but we're not quite there yet, unfortunately.
Right.
We'd love to be able to, but we're not there yet.
Yeah. Well, thank you very much. Thank you.
Nice to see you. You've grown a beard, I see.
I have. Yeah. Thank you. It was good to see you. Yeah.
Thanks. We have a question from Professor Sanjeev Sabnis.
Yeah, Professor Vidyasagar, how do these models capture the randomness that is present in the data?
Oh, we don't. You just appeal to the law of large numbers. The randomness basically is ignored. I mean, that's the honest answer. See, that's why, for example, if somebody were to ask me, can you apply your Sutra model to predict the number of cases in a ward? I tend to forget it, because at those very small numbers, the law of large numbers doesn't apply at all. So it is a what I'll call a coarse grain model. It is not a fine grain model.
Okay. Thank you. So I presume that the time series models would would highly become applicable and would yield some interesting results.
Well, see, the point with the time series models is there are two classes of time series model. Some people do just what I'll call moving averages. Moving average models cannot capture long-term trends. For example, it will never be able to predict the going up and then the coming down. For that, you do need a nonlinear differential equation model. Whereas the time series models are inherently short-term linear forward prediction. So they cannot capture that kind of a phenomena.
Well, I was referring to maybe Box-Jenkins kind of models, I mean, those class of models, ARIMA models, etc. I mean,
well, ARIMA model is essentially a linear model. I mean, you can put in nonlinearities, but you have to postulate the nonlinearity first, and that's what we're trying to avoid doing. So we don't want to guess, for example. So if you assume everything is linear, you just have a linear ARIMA model, and we didn't want to do that. So I think there's one more.
Okay, thank you.
Thank you.
Thank you.
Yeah, Rajdeep, please go ahead.
Yeah, thank you, Professor Vidyasagar. Very nice talk. I was curious about the bimodality in the South African peak you briefly mentioned. I was just wondering, in India, always all waves have come with a single modes, but there are many countries like UK, I think Israel also, and like you showed for South Africa, there is a bimodality. So is there any way to capture that in a model other than changing the parameters in terms of some fundamental new unit being added in the Sutra model? Or is there a thought like that?
No, it's a very good question. See, there were two separate phenomena I was mentioning. One is the multiple waves. If you look at UK, Israel, Germany, US, they're all having multiple waves.
Correct.
And the reason why they're having multiple waves is because, well, somewhat politically incorrectly, perhaps it's a reflection of the duration of protection afforded by the vaccines that they're using. Okay. So that is why they're in a sort of endless loop of booster after booster after booster. Okay. Now, in the case of South Africa, let me tell you, the vaccination rate is very low. Only 41% of the adults are vaccinated.
Okay.
So what I was referring to about is not the multiple waves, that is one point, But also, if you look at the third wave, why is it not just going straight down? Goes straight up. It should go straight down like the previous. I mean, numbers may be different, but qualitatively it should look like this. But it doesn't.
Yeah.
Goes up, comes down, and it takes a U-turn. And when we calibrated the models, there's more than a doubling of the beta. Now, to answer your other direct question, when you try to fit this for other countries, say US, UK, which we have done, you see the similar increase. So what happens when this happens, say, for the US? So beta increases, okay?
Right.
And why does beta increase? Because the population is no longer protected against the virus. But in our view, that cannot explain this because this is too short term and this increase is too big. So we're in the phase where we just draw attention and then ask people to examine this phenomenon. Have I answered your question? I hope
Yeah,
I'm not answering it. I hope I'm not answering a different question than the one you asked.
No, right. I was kind of asking that there is this bimodality within a wave, which we have not seen in India any time.
Nowhere else, by the way. Nowhere else. Even in US, UK, they have multiple waves, but each wave by itself is unimodal. But South Africa is unique in that within the wave, you have a lack of unimodality.
Can I ask another quick question?
Yeah, please.
Okay, so it was very interesting that you mentioned about AI ML. So I was just wondering, I am not in that area, but as a outsider, that you mentioned COVID-19 tracker will provide more friendly data or more more accurate data maybe. So how is that going to help the Sutra model or any future generation of such kind of model?
No, I guess I didn't explain very well. See, there was this website called covid19india.org.
Right.
And they stopped functioning as of 31st October of last year. So we took up on the task of maintaining the daily data. Before October 31st, I was also an avid user of that website. And we took the decision in about September 15th that we have had about 45 days to replicate the functioning of that website. So that's when we started looking at the various bulletins put out by the state governments and so on, and found out that they were terrible. I mean, they were completely non-digital. Some people were putting up a PDF file. So the only way to extract numbers from the PDF file was to do it manually. Almost nobody was putting out a spreadsheet. That would have made our life so much simpler. That's what I meant. But right now, I think ours is the most comprehensive website. It's called COVID-19 Tracker.
Okay. So my question was that how you mentioned more AI ML can come into the picture. So is it like more localized data or localized pattern evolution there? It will make an impact?
Yes, that was the question that the other gentleman asked. I couldn't catch his name, who was asking about Box-Jenkins model. So if you want to use methods of that type, then you really need much more reliable data and also capture the inherent stochasticity, which is what he was asking about. And then you can use models like ARIMA and so forth.
Okay.
So we had a kind of a choice to make. Do we go top down or we go bottom up?
Right.
And we felt that bottom up is not going to work because the quality of the data was not good enough.
Correct.
So top down was a better approach, we thought.
Thank you. Thank you very much for your excellent work. And I can say that your model predictions kind of provide a large amount of psychological comfort, which is at least true. I mean, I used to see the model and I knew May 15th will be problems over or something like that in April.
Yeah, that's well, I mean, look, I'm not trying to brag, but we did put our neck on the line by making a verifiable prediction, right?
Right. No, but it was true in my some cases, at least in my case. I just wanted to mention that. Thank you very much.
So thank you. My pleasure.
We have a question from Niranjan.
Yeah, Professor, thanks for the lovely talk. And my question is related to the previous respondent. I'm a management scholar. Maybe I missed some of the crux of the mathematical stuff. But my question is, where do these predictions factor in the human psychological aspect, which is like, just like the previous questioner, if I see a forecast that is very gloomy, my behavior changes. I start becoming very cautious. I don't venture out. And if I see, so the thing is, when you predict a steep wave, that will actually impact the behavior of at least a large section of population, not everyone. Those who have to go for daily wage labor, they will anyway go regardless of the thing. Yeah. But those who have options like, going for a sport or a movie, half the population would restrict that. So it becomes like, the uncertainty principle. You make a forecast, and the more confidence I have in the forecast, the more I will alter my behavior in response to your forecast. So this I would presume is true of maybe half of the population, which is enough to move your forecast. So where does this figure in your modeling?
It reflects in the value of beta, which is the contact rate. So it's not just a question of whether people are going out or not. It's
because
also
the
a question
of make some.
but it's also a question of whether they're properly protected when they go out. For example, if people stop wearing masks and stop following COVID appropriate behavior, then beta goes up because the likelihood of infection goes up. So that's how we capture it. So when people become complacent, then beta will go up, and we can capture that.
All right. Yeah. Thank you.
If there are no other questions, I'll just have one question. How many of the learnings from this tracking could be generalized to maybe other epidemics or future pandemics? Can we get a warm start? You did get a warm start from the South African data. Could this provide a warm start in the future?
Well, so we looked at that question very carefully. If you look at the team, Professor Manindra is a mathematician or computer scientist. I guess I would be called a theoretical engineer. And General Kanitkar is a proper medical doctor. See, one of the questions that often comes up is the incubation period. It turns out various studies have shown mathematically, not just in this case, but in other cases, that eventually the incubation period, if it is very short, doesn't really matter. You can just ignore it because it will be captured in the fluctuation of the parameter. But if you have, diseases like say dengue, for example, or chikungunya, which as I understand can lay dormant for a very, very long time before coming up again, it's not clear how we can capture that. So, I mean, if somebody has the idea of working with us on this to capture other communicable diseases, we'll be very open to that. But we're very honest that we ourselves don't have enough knowledge base within the group. Yeah. So if others want to join in our venture, we'll be very happy.
Thanks, Professor Vidyasagar. I'm assuming there are no more questions. So let's extend our warmest gratitude to Professor Vidyasagar for a very enlightening presentation. I would say even more enlightening discussion. Look forward to more interactions with you, Professor Vidyasagar.
Certainly.
Probably
Thank
have more students take up with some of these futuristic problem directions with you. Thanks. Yeah.
Yeah.
Thanks.
Okay. Thank you very much.
Thanks. Yeah.
Bye.
Bye, everyone.